Hi everyone, I'm Dr. Divya Desa. Welcome to my channel Ace Anatomy. Today I'll be taking anatomy beyond the books as I discuss the lesions of brachial plexus in this new exciting Anatomy in Practice series. I will show how anatomical concepts come to life in clinical practice, making anatomy more relevant, engaging and indispensable. So hit the subscribe, ring the bell and join me. There are two lesions of brachial plexus. One is the Erb's palsy, or also known as Erb-Duchenne palsy, and Klumpke's paralysis. So before we get into the lesions, let us try to recall some of the anatomical concepts of brachial plexus. So one is the Erb's point. So what is this Erb's point? So it is the point where six nerves meet. So which are those six nerves? One is the ventral rami of C5 and C6. These two rami join to form the trunk, that is the upper trunk, and the two branches given by the upper trunk, that is the suprascapular nerve and nerve to subclavius, and this trunk further divides into anterior division and posterior division. So it is the point where these six nerves meet: the ventral rami of C5, C6, suprascapular nerve, nerve to subclavius, anterior and posterior division of upper trunk. Let's now look at the segmental control of movements occurring at the shoulder joint. So adduction of the shoulder joint is controlled by the C5 spinal segment, and abduction of the shoulder joint is controlled by C6 and C7 segment. Flexion of the elbow is controlled by C5 and C6 segment, and extension is controlled by C6 and C7 segments. And the flexion of wrist and fingers is controlled by C8 and T1 segments. This segmental control is important in understanding the features of the lesions of brachial plexus. Now let's look at this clinical case. A baby boy was delivered in the hospital by an obstetrician by forceps delivery. 2 weeks later, the baby was taken to the pediatrician for checkup. And while examining, the pediatrician found that the baby's right arm was medially rotated and adducted, while his forearm was extended and pronated. He also noticed sensory loss on the lateral aspect of the right upper limb. So name the clinical condition, name the site of lesion and the cause that produced the condition, and give the anatomical basis for the clinical condition. So whenever we try to analyze a clinical case, we need to look at the keywords. So what are the keywords here? So one is the forceps delivery, and while examining, the right arm was medially rotated and adducted, and his forearm was extended and pronated. And there is sensory loss on the lateral aspect of the right upper limb. So these are the keywords. So first we will see where is the site of lesion. The clinical case here is suggestive of Erb's paralysis. So where is the site of injury or in Erb's paralysis? So it is at the Erb's point. So Erb's point, we learned that it is the point where the six nerves, that is the ventral rami of C5 and C6, the suprascapular nerve, the nerve to subclavius, and the two divisions of the upper trunk, anterior and posterior division meet. So this is the point. Okay. So now these two nerves, that is the ventral rami, are involved. Suprascapular nerve, nerve to subclavius is involved, and we will see which are the nerves involved which are coming from anterior and posterior division. So here the anterior division would have joined with the anterior division of that is of the upper trunk would have joined with the anterior division of the middle trunk to form the lateral cord. And one of the important nerve given by the lateral cord would be the musculocutaneous nerve, which will be having the root value of C5 and C6. And the posterior division would have joined the posterior divisions of middle and the lower trunk to form the posterior cord. And one of the important nerve which will be supplying near the shoulder joint region, carrying this and will be carrying the C5, C6 segments, is the axillary nerve. Okay, because we learned in the segmental control that the movements at the shoulder joint and the elbow joint are mainly carried by the C5 and C6 segments, spinal segments. So here the nerves which will be containing these root values are: one is the musculocutaneous nerve. You know why? Because it is coming from the upper trunk, which will be having these two root values, and axillary nerve this is given up in the axillary region itself, in the upper arm region, so around the shoulder joint, and it will be carrying the C5 and C6 segments. So in Erb's paralysis, there is injury of the upper trunk, and this injury is caused by the excessive increase in the angle between the head and the shoulder. So this can occur in two conditions. One is during the delivery, when there is excessive traction here between the arm and the head. And other one is during a fall where we land on the shoulders, and this increases the angle between the head and the shoulder. So this leads to injury of the upper trunk and mainly the Erb's point, leading to Erb's paralysis. Now let's look at the clinical features of Erb's paralysis and its anatomical basis. So the typical deformity what we see here in Erb's paralysis, where the arms are adducted, medially rotated, the forearm extended and pronated, is known as the policeman step or porter step or waiter step deformity. So what is the anatomical basis for this? So here the adduction of the arm. So the arm is in the adducted state because it is unable to abduct. Okay, so why there is loss of abduction? Because of the paralysis of deltoid. Now why paralysis of deltoid? Because the nerve involved is axillary nerve. Okay, so basically the C5, C6 segments are involved, right? And the axillary nerve root value is C5, C6, and axillary nerve supplies the deltoid muscle. So there is paralysis of deltoid, so shoulder abduction doesn't take place and the arm is in an adducted state. Then coming to the medial rotation of the arm. Why is the arm medially rotated? Because the opposition movement, that is the lateral rotation, is not possible. Why is it not possible? Because of the paralysis of these muscles, that is the supraspinatus, infraspinatus and teres minor. Now the supraspinatus and infraspinatus, they are supplied by the suprascapular nerve, and teres minor by a branch from the axillary nerve. So suprascapular nerve, where was it coming from? Again from it's a branch of the upper trunk of brachial plexus. So the root value will be again C5, C6, right? So that is why we have this arm in the medial rotated state where lateral rotation is not possible. Then there is extension of the elbow, that is forearm is in extended state. Okay, so extension of the elbow, basically it is by the C6, C7 segments. So C6 segment is that is musculocutaneous nerve supplied by which supplies the biceps brachii. Okay, so there is no flexion there. Flexion movement is lost because biceps brachii brings about the flexion, and musculocutaneous nerve is paralyzed there. Nerve involved is musculocutaneous nerve, which has the root value of C5 and C6. Then the forearm is pronated. There is pronation. Now pronation here because of the paralysis of the biceps brachii muscle. Okay, because biceps brachii, it brings about the supination of the forearm. Okay, it brings about the supination of the forearm. And again biceps brachii, why it is paralyzed? Because of the involvement of musculocutaneous nerve. And this was the motor loss. And what is the sensory loss involved here? Sensory loss is there is loss of sensation along the lateral aspect of the arm. Now why lateral aspect of the arm? Because of the involvement of the root of C6 spinal nerves. Okay, so they will be supplying giving the cutaneous supply here. Okay, C6 spinal nerve. So that is why it is involved here. The sensory supply would be going through the C6 spinal segment, and since it is involved here, there is loss of sensation along the lateral aspect of the arm. Now let's take a look at the second clinical case. So here the baby was delivered by breech with the arm extended. While examining, the pediatrician found that the baby had a droopy left eyelid and claw hand. He also noticed sensory loss on the medial aspect of the left forearm and hand. So name the clinical condition, name the site of lesion and the cause that produced this condition. Give the anatomical basis for the signs observed by the pediatrician. So what are the key words here? One is the breech with the arm extended. So the baby was delivered by breech. And next is the droopy left eyelid and claw hand and sensory loss on the medial aspect of the left forearm. So these are the keywords. The clinical case here suggests that it is Klumpke's paralysis and the site of injury is the lower trunk. So this lower trunk is formed by the ventral rami of C8 and T1 and it gives anterior and posterior divisions. So the anterior division here continues as the medial cord and the important nerves supplying the forearm which come from this medial cord are, one is the median nerve which supplies all the flexors and the ulnar nerve which supplies all the intrinsic muscles of the hand, and we have the medial cutaneous nerve of forearm which supplies the skin over the medial aspect of the forearm. So now let's look into the clinical features. We now know that the cause for Klumpke's paralysis is the injury of the lower trunk. So what causes this injury? It is mainly because of the hyperabduction of the arm, which may occur when one falls on an outstretched hand or when hanging on to a bar or something, when there is hyperabduction here or overstretching, or during an extended arm delivery. Okay, so this can lead to the injury of the lower trunk. Now let's look at the clinical features of Klumpke's paralysis. So the typical deformity which we see here is the claw hand deformity, and this deformity is mainly because of the paralysis of flexors of the wrist and fingers and involvement of all the intrinsic muscles of the hand. Again, there is paralysis of this, and that is mainly because the intrinsic muscles are supplied by the ulnar nerve and partly by the median nerve, and the flexors of the wrist and fingers, they are the flexors which go from the forearm, right, and they are supplied by the median nerve, and there is loss of sensation along the medial aspect of forearm and hand because of the involvement of T1 spinal nerve, okay, which are carried by this medial cutaneous nerve of forearm as well as the ulnar nerve, which also gives sensory supply to the medial aspect of the hand. And sometimes we see Horner syndrome, which includes ptosis, that is drooping of the eyelids, meiosis, where there is constriction of the pupils, and hydrosis, where there is loss of sweating on the face, and enophthalmos, where the eyeball is sunken within the socket. So this is mainly because of the involvement of the sympathetic fibers which supply the head and neck region and leave the spinal cord through the T1 segment. Okay, but you should remember that this Horner syndrome occurs only if the T1 is injured proximal to the white rami communicans to the first thoracic sympathetic ganglion. And that's a wrap for today's episode of Anatomy in Practice. I believe I helped you connect the dots between theory and clinical correlation. So if you found this video helpful, don't forget to like, share and subscribe to ACE Anatomy. Hit the bell icon so that you never miss out on the next exciting exploration into the practical wonders of anatomy. See you in the next series. Until then, happy learning.